Hello everyone, hope you all are doing good. So in today's video, we will learn and solve some PYQs in OBGY which have high chances to be shown up in the upcoming FMGE exam. So let's get started. So question first says, 32 years old unmarried woman came with secondary amenorrhea. She was having regular normal flow periods until now. Nothing was found on pelvic examination, no other associated complaints. What will you do next? We have four options: LHFSH testing, estrogen level, USG, or urine HCG. Here we can see she had the periods before, that's why it is secondary amenorrhea, but missing her recent periods. Pelvic exam is normal without any other complaints, so we should doubt pregnancy in this case. Don't get confused with the word unmarried and give priority to the pregnancy test. So, out of given options, we do urine HCG for pregnancy. So, the answer will be option number D. Next question we have, what is the common obstetric gynecological condition where this procedure is done? So here we have a diagram. The options are dysfunctional bleed after hysterectomy, atonic PPH or postpartum hemorrhage, recurrent bleed from CA cervix, bleed from CA vulva. So here we see the posterior branch of interior iliac artery. You can see it is being very clearly mentioned here. It is being ligated or clamped, which illustrates a very conventional method of control bleeding after postpartum hemorrhage, where the bleeding increases multiple times due to the loss of tone, leading to failure of contraction and hence hell lot of bleeding. So the correct option here is going to be option number B, atonic PPH or postpartum hemorrhage. Question number third says, which of the following is an absolute contraindication to IUCD insertion? Options are unexplained vaginal bleeding, history of previous PID or pelvic inflammatory disease, previous ectopic pregnancy, or HIV positive status. Now let's know some of the absolute contraindications of IUCD insertion. First, we have unexplained vaginal bleeding. Second, we have is active PID. Third is pregnancy. And the fourth and last one is distorted uterine cavity. This is not it. We have a long list of contraindications for IUCD insertion, but the highlighted or the main ones are written here. So option B would be correct if the time period of the PID was less than 3 months or within 3 months of IUCD insertion. Since no time is given in the question, we will go with option A, which is the most suitable here, and that is unexplained vaginal bleeding. Let's focus on question number 4 now. It says a male had a vasectomy 1 month ago. Even after the procedure, his wife is now pregnant. What advice should have been given? A says use condom for 3 months, abstinence for 3 months, OCP for 1 month for wife, or 1 month hormonal contraceptive for man. Now, this is a bit tricky question, focusing on the doubt as how come is it possible to have the pregnancy even after the husband underwent a vasectomy. So the concept lies in the fact that the male partner has the capacity to impregnate his wife even after vasectomy due to the remaining amount of semen along with the sperm in the reproductive tract of male, which usually takes up to 3 months to get released completely, making the male possibly fertile up to 3 months of vasectomy. So the correct option goes as option number A, that is to use condom for 3 months. Option B is not something which you want to advise to the patient, or patient may not be able to do it. So we will go with the best choice, that is option number A. Question 5 says, a lady presented with complaints of foul smelling, grayish white discharge, and a whiff test on the discharge was positive. On examination, clue cells were seen on microscopic exam. What is the condition and which is the drug of choice for the treatment? Option goes as Candida, treatment fluconazole, Trichomonas metronidazole, Gardnerella vaginalis metronidazole, and Gonococci doxycycline. So in this question, we have direct hints like whiff test is positive. Clue cells being observed in the pathology exam. The complaints of foul smell, grey discharge, along with the finding confirms the diagnosis of bacterial vaginosis. So the patient has bacterial vaginosis caused by the bacteria Gardnerella vaginalis, and drug of choice for this condition is metronidazole. Here I got you the image of clue cells, which are just epithelial cells of the vagina, and the Gardnerella vaginalis bacteria are attached on it. So the correct option here goes as option number C, that is Gardnerella vaginalis, and the treatment or drug of choice for the treatment of bacterial vaginosis is metronidazole. Let's talk about question number 6, which says during an antenatal visit of pregnant lady of 20 weeks, the fundal height is only 16 weeks, which is obviously less than the normal. USG done shows no amniotic fluid. Which abnormality is likely to be seen in the fetus? Option goes as renal abnormalities, anencephaly, gastroschisis, and esophageal atresia. So, the patient has no amniotic fluid with less than normal fundal height, which suggests anhydramnios or EPRA, which is also known as early pregnancy renal anhydramnios, which is caused by the fetal kidney problems, agenesis or malformation, preventing baby from producing urine, leading to a severe lack of amniotic fluid by mid pregnancy, that is about 22 weeks of the gestation. So the correct option here is option number A, that is renal abnormalities. So that's all about today's video, guys. I hope you found it helpful, and if you do so, please like, subscribe and share it with your friends. Thank you for watching. See you in the next one.